Thanks a lot for having me here. And I'm so lucky to be able to go right after Danny because he just gives half of my talk and just introduces all the concepts. And I just get to kind of float through and just describe some examples. So this is why we are really working in tandem. And I'm really, really excited to be here with JD and Danny as well. And thanks to all of you for being here this morning. So hopefully I can advance slides, no problem. So I'm going to talk about, okay, so you have an evidence-based practice, now what? And basically the journey from your efficacy and effectiveness studies to your first implementation study. And basically this is based on probably a lot of mistakes I've made, but also just in general, some opportunities that had I been making perfect the enemy of the good, it would never have happened. So just something to think about. But the first thing I wanted to talk about is why we care about these things. And it's because basically we have a persistent translational gap. And we really don't have a lot of pathways in our PhD or MD programs to figure out, okay, what do you do once you have an effective intervention and how do you actually make it into essentially something that could be implementable? And we have the traditional research pipeline, which you've probably seen this figure a lot. It's from the article about describing all the different study designs for implementation and things like that. And it's just very progressive, but also very slow. And we really need to get to the point at which we can actually implement things much more readily. So why should we care about implementation science? And this is probably something you all know, but I always like to make this argument when I've talked to a lot of other translational researchers, because they think that oftentimes if you publish a paper or if you have a treatment that's blockbuster, that everybody's going to use it and the world will be happy. And that's often not the case, because essentially you actually have to ask yourself, are people actually going to use it? Kind of how Danny described it earlier. Are practitioners trained to actually use the intervention? Are trained practitioners choosing to use the intervention or treatment? And then do patients actually benefit or actually use it to begin with? And so if you sort of get the slippage between these 3 or 4 stages, you really only get a fraction of the benefit of the treatment, because there's really this idea of what, Danny, you described brilliantly earlier, that there's a lot of provider behavior that happens in between the effective treatment and things that you want to actually make sure patients get. So this is basically a slide I've stolen from Jeff Curran's work. He's published a lot of really great articles really describing implementation science. And I love this slide because it just basically describes in very sort of straightforward language what we're doing. And basically I'll go through this quickly because in many respects, you may all really kind of internalize a lot of these things, but the practice or innovation treatment is the thing. And basically in effectiveness research, we ask the questions, does this thing work? And for implementation research, looks at how the best to help people and places do the thing. And implementation strategies is what I think, Anna, you brought up earlier. What are they? And I think basically they are the strategies, are the stuff we do to try to help people and places do the thing. And then most implementation outcomes really focus on how much and how well you do the thing. So essentially your primary outcome for a typical implementation study is the uptake of the treatment itself, and the secondary outcome is whether or not patients benefited. So the goal of implementation science is to identify the best implementation strategies to help us scale up an effective treatment. But how do we identify promising implementation strategies and apply them into practice? And what does it actually mean? This is where you, as an effectiveness researcher, or in my case, when I was doing this 20 years ago, clinical trials, where I was basically having a study coordinator or a research assistant deliver the treatment to different patients groups and things like that, I was basically going to lose control, meaning that I was going to rely on existing providers to deliver the treatment, not someone I employed on my study team. And a way to think about this is something we published a few years ago out of our Quality Enhancement Research Initiative Query program, because what we found was people often would get they get really well trained in efficacy and effectiveness research and go to their first seminar in implementation science, and they might learn about these exotic models like the consolidated framework for implementation research and things like that, but they wouldn't actually know the steps taken. And so in Query, because we're an embedded program that does implementation science within a national US healthcare system, where providers come to us and ask us, what's the difference between implementing and implementation science? We wanted to put together a roadmap for actually helping people think through what are the steps taken to actually basically take a treatment and get it implemented. So the implementation roadmap has 3 phases that follow the learning health system framework cycle that Chuck Friedman and others had developed as part of understanding how a health system really uses a continuous learning cycle. And so the pre-implementation phase is basically asking, essentially, what's the problem we want to solve? Who are the players that you need to involve, the interested parties, the stakeholders, that the people, the frontline providers, clinical managers, patients that you need to involve to help solve that problem? What are the best practices? And if you have treatments that are effective, essentially, do you have to adapt them? And how do you adapt them? Do you have core elements? Do you know what your core components of the interventions are? Or do you need to create a whole new intervention because it's just way too different in the population that you want to help solve the problem in? And the implementation phase is really focused on, okay, what are some of the things we need to do to change provider behavior to have existing providers implement this intervention, or if we just need to do more research and a new intervention altogether, and then essentially monitor what the outcomes might be and evaluate it and so forth. And then the sustainment phase is basically you have your definition of done. You're done with your implementation study. This is a very broad overview of sort of like how to do these things. How do you actually train and teach practitioners and healthcare leaders how to continue the maintenance of implementing that treatment over time? So you back off, you provide not only the manual of the effective intervention or treatment, but the manual on how to implement it. And that manual on how to implement it is essentially your collection of implementation strategies that you found to be effective in changing provider behavior so that existing providers would effectively implement that treatment. So 2 layers of manuals. First manual is your treatment, your thing, and then your second layer of manuals are your manuals for the implementation strategies. So implementation strategies are typically highly specified and, anyway, but they're highly specified, effective ways in which they're theory-based that basically focus on provider change. And these are examples of implementation strategies that essentially, I would say, roughly categorize into 2 different types of implementation strategies. And this categorization is based on Bruce Savolio's work, who really actually developed a lot of, in the School of Business in the University of Washington, developed a lot of leadership training programs for individuals. And he really differentiated servant leadership into transactional leadership skills and transformational. And they actually map on quite nicely into 2 main buckets or categories of what these implementation strategies would look like. The first are what I would call strategies that push the evidence-based practice or treatment into the real-world settings, and you basically sort of show providers how to use these treatments. Typically, they include patient safety checklists, rapid cycle testing, which is what you do your plan, do, study, act cycles in a clinic, audit and feedback. You audit whether or not providers are using a treatment. You provide feedback on how to help them deliver the treatment better, and provider incentives to some extent. These are things like financial incentives and so forth. But there are also strategies that pull from the local level to drive practice change. Sorry, this is not coming up quite well, but I can just talk through it. They're the ones in sort of the purple, the blue boxes, which are community engagement. So you're seeing that it's a lot more focus on interactive problem solving, interpersonal skills, a lot of strategy thinking, a lot of that, what I call businessy types of skills. And they also include coalition building, an implementation strategy called facilitation, which uses a whole bunch of strategies to build that interpersonal relationship between the frontline providers and empower them to basically implement these interventions, as well as using clinical champions. So some examples of how relationships between this implementation strategy could basically overcome the barriers to implementation are basically listed in this slide here. So for example, you might have interventions not designed for a specific population. So the opportunity there is you get providers and consumers to provide input to you about how that intervention or that thing could be tailored better to be able to make it more implementable in the routine care practice. And oftentimes in the past, people have often used rapid cycle testing in a routine clinical setting, or they've used user-centered design. Another component, part of that, is basically just holding a focus group of frontline providers and consumers and asking them, okay, these are the core components of this intervention. Can you help us maybe tailor it to your population? Or even better is actually just to come and say, look, we know we understand we have a common problem here to solve. Maybe the number of the suicide rate among veterans, for example, has skyrocketed. How do we solve this problem? So you get together a group of frontline providers and clinicians and consumers, veterans, who firsthand experience suicidal ideation among veterans, and basically ask them, these are the array of different evidence-based programs or treatments. How should we adapt them to the veteran population? What should we do? And when you do that kind of user-centered design thinking with the people most affected by the treatments, they give you a lot of great ideas and some of the best ideas for the option of adapting that treatment or intervention. And most of the time people think, well, isn't that creating a new intervention? Do I need to do another effectiveness trial? Do I need to do more research? Sometimes it's not, because a lot of times interventions pretty much have the same core components. You just basically tweak them. And a lot of those adaptations are fine as long as you basically, again, manualize and specify what your core elements are of your treatment or intervention, and give frontline providers the option to adapt within certain parameters. And we see this a lot, and we've seen this in the last 20 years with the collaborative care model intervention, which has been widely used to improve physical and mental health outcomes by providing more of a chronic illness care focus in primary care settings. It's the same 3 or 4 different elements: self-management, care management, provider guideline support, things like that, having a registry. There's core elements have pretty much remained the same, but the way that they were tweaked to different populations or treatment settings have changed. But essentially, just having an understanding what your core elements are of your intervention are really important to basically be able to differentiate and when you can adapt without going off kilter and creating a whole new intervention versus basically just adapting something that already has been grounded into core elements. But these are just examples of where the opportunities are for overcoming the barriers and the types of implementation strategies that you can use. For interventions rolled out with limited planning or provider input, that's where you might want to use something more interpersonal, like facilitation or coaching as an implementation strategy, where you work one-on-one with frontline providers and work out individual barriers and provide to them the skills that they need, the strategic thinking skills that they need to sell that intervention or treatment to their leadership, and basically also provide more guidance and selling that intervention or treatment to their other colleagues so that they become empowered as a change agent. And then if you have intervention reach is hard to sustain, then you think about other types of financial or non-financial incentives to sustain that intervention over time, such as audit and feedback and other types of strategies as well. So one example of using a bundled implementation strategy, where you take discrete implementation strategies and you put them together and you have essentially a program of implementation, is the Replicating Effective Programs. And REP was developed in the 1990s by the CDC to rapidly translate HIV prevention interventions into routine community-based settings. This was at the time when the highly active antiretroviral therapies were just coming out, but there was a rapid surge of HIV infections. We didn't have the types of PrEP or anything back in the day. And basically, what we needed to do was really reach at-risk and marginalized community populations with basically training and skills for them to be able to prevent the spread of HIV and so forth. And so REP was really developed based on theories around social learning theory, action anthropology, Rogers' diffusion of innovation. But really the core components of the REP implementation strategy bundle included pre-implementation work where basically you do essentially the same things. And the query roadmap is largely based on REP, but it really focuses on 2 areas. One is you not only engage with the key stakeholders and the people most affected, but you also basically what we call package the actual intervention or treatment. And packaging was something that was distinctly called out by the CDC as a very important component of REP. You write the intervention manual in user-friendly language. You have all the materials you need for that guidance counselor or that person running that outreach program. You have everything you need in this package. And basically you differentiate the core elements of that intervention. And these were all behavioral interventions. A lot of them were like cognitive behavioral therapy based interventions. So you had certain skills you conveyed to other individuals. And then you allowed and gave people options to adapt it based on certain settings. And so that packaging stage is really important because it allows that technology transfer to happen. It allows the more ease of use in the field, in the community-based settings where they didn't have to read a scientific article that's very dense to understand how to implement a certain intervention. They had it all spelled out. And what they also had spelled out were options for them to adapt it. And that gave people a lot of flexibility to be able to basically run an intervention without having to go very rigid in terms of how to actually do it. Now, the other core component was the implementation phase, which they did a lot of front-loaded work around training and providing technical assistance. We added facilitation to our enhanced rep program because we felt that we needed more than just technical assistance, and that's that transactional skills building. We needed more of that transformational skills building, which meant like more interpersonal skills building with frontline providers. And then finally, sustainability is really monitoring the impact, making the business case for both the intervention and the implementation strategies, and handing that to the future program leads who would then continue that work beyond the researchers. So this is also something I want to provide an example of. You hear more about this, are essentially the Enola Proctor's way of specifying your implementation strategies. So now we're sort of segue into the reason why we do a lot of this work and why we manualize not just the intervention, but the implementation strategies. We want to be able to replicate these over time. So REP has been replicated because we essentially were able to replicate all the processes of the packaging, the training, technical assistance, and facilitation. So one example of how you can actually sort of outline what an implementation strategy looks like is use the Enola Proctor framework of the actor action framework. And this is an example of facilitation and a particular type of facilitation our team has used, which is all virtual, and it's been done nationally, where we provide essentially interactive problem solving in a context of a supportive relationship, so that facilitator, who's the implementer, provides that kind of, gets that kind of rapport going with the frontline providers and helps them to implement an evidence-based practice by basically in 5 main ways. First is benchmarking where that provider is in terms of implementing the evidence-based practice, finding a way to monitor the process by which they try to improve the practice and get the evidence-based practice used, and then essentially figure out who can be responsible in their team to help with the implementation. Also develop an action plan to support the team, mainly that they develop a plan for how to improve it. They also make the business case, meaning that they collect data on how well they're implementing that evidence-based practice and provide that information to their leadership, and also provide very important data around the added value of implementing that evidence-based practice, and also showing the change in the uptake of that evidence-based practice that's benchmarked to quality and outcome indicators of most interest to the leadership of that practice or organization. So you always want to speak the language of essentially what the leaders care about or what keeps them awake at night and running their organization. And then having a plan for sustainability. But this essentially is an outline of, we can have a lot of these different outlines for different implementation strategies. This is just one example that we'll be talking more about down the road as an example of an implementation strategy. So in getting to implementation strategies, Jess Curran laid out really nicely the hybrid effectiveness implementation designs or studies. And so this is a schema of what these designs look like. And we heard a little bit earlier from Danny about essentially what an effectiveness efficacy study is for an implementation trial and things like that. So I'm going to kind of walk through, though, from the perspective of you're a researcher and you're going to run your first implementation study, and how do you actually build your team to do that? So when you've done a sort of a traditional clinical effectiveness study, you essentially most of the time would have your study staff deliver the intervention, the thing. Essentially, so you've hired a psychologist or a social worker to deliver a mental health evidence-based intervention, and essentially it's tightly controlled, and basically you mainly care about, does this treatment work? A hybrid type 3 on the other end of the spectrum is when you have a manualized intervention that's shown to be effective already, but you don't know exactly which implementation strategies will work best, but you've manualized your implementation strategies like you have rep and facilitation. And then essentially you compare the effectiveness of rep only versus rep plus facilitation, and you do a multi-site cluster randomized controlled trial. Your main outcome is the uptake of the evidence-based practice. You're basically relying on existing providers to deliver that evidence-based practice. And then your interventionists are the implementers. You may actually hire them on your study team, or they may be existing people as well in the field in these practices, but you have a separate facilitator who basically provides facilitation, and a separate, essentially rep specialist who provides the rep training components and so forth. But all the providers who deliver the actual intervention to patients or clients, they're all existing providers in the real world. Hybrid type 2 designs are really interesting because essentially those are that's like your step in between effectiveness and a full-blown implementation comparative effectiveness study. Your hybrid type 2s are essentially testing both clinical interventions and your implementation strategy. And I often consider these the first step to basically doing a full-blown implementation of something. You are basically in a hybrid type 2 testing out whether or not your first followers are doing the treatments as you planned. Your first followers are essentially, you might have actually developed a treatment that's effective. You may have developed the actual intervention. Maybe you're the person developing cognitive behavioral therapy for a certain population and so forth. But you've always hired and trained the people delivering the CBT. Now you're going to take a step back for the first time and basically allow existing providers to deliver that cognitive behavioral therapy. And what you need is a good manual, a good training program, and a good way of measuring whether or not providers are using CBT effectively, and a good indicator of whether or not patients are getting CBT. And essentially, you need those types of methodologies solid before you go into a hybrid type 2. But a hybrid type 2 can also help you pilot implementation strategies. So that's when you may not know, well, maybe I'll use facilitation, but I'm going to change it to maybe include a lot more equity-focused issues or include more community engagement. So a hybrid type 2 design is a wonderful way to pilot test and do some exploratory work on implementation strategies. So again, these are just examples of the 3 phases of implementation studies and the types of designs that have been used. So another way of looking at the hybrid design overview is here is basically you can see how the design characteristics are different, the questions are slightly different, and the unit of analyses are slightly different as well, and where the key advantages are. So sometimes you often have to do a hybrid type 2 design because you might be in a situation where you work for an organization like VA, and they might ask you, like the VA does a lot, you know, we have a suicide prevention program, we want to roll it out to everyone now. You know, has it been tested? Not really, but you can kind of do both the effectiveness testing of it and the implementation at the same time by designing a hybrid type 2, where the intervention gets rolled out and your main primary outcome is still effectiveness, but there's also an implementation outcome, and you use some different strategies to roll it out. So getting implementation strategies to advanced health equity. By the way, I think implementation science and health equity really go hand in hand. They're baked into each other. And if you think about what is really the most important here is that you want to be able to get all the treatments to all the populations faster. I mean, essentially, you want to be able to not have that gap and not have some groups get treatments faster than others. Implementation science seeks to solve that. And so another way of thinking about it is the fact that you're identifying gaps in healthcare and outcomes, and that's sort of that first phase of the implementation roadmap from Query. And then you basically are determining what's driving that variation in the gaps. It could be just a lack of access to effective treatments, and then designing and testing your implementation strategies. And in each phase, there's really different ways in which you are going to engage different frontline providers and end users. So you want to engage your key interested parties at the beginning and basically identifying the common problem to be solved and also the metrics by which you measure success. Can you actually get some really good metrics, ideally from secondary data sources like electronic health records, things like that, to actually understand, are you making a difference? Are you closing that equity gap? And then understanding the driving the variation, basically there's really ways in which you can essentially identify firsthand, and this may be the work you do before you design your first implementation trial, is go to the places where they're actually doing a really good job of essentially solving a problem. Maybe there's sites in the VA, for example, that have really drastically lowered veteran suicide attempt rates, and you want to figure out what they've done. Learn from them and see what best practices they've used and see if they've used effective practices. And they may have organically used implementation strategies, like they may have a really charismatic champion there who's essentially training different providers on how to do suicide prevention assessments for veterans or something like that. So you may want to think about understanding and studying what they call positive deviant sites to understand what actually is happening already, so you have a sense of how to build your implementation study. And then basically during the design and test implementation strategy phase, that's like a hybrid type 2 or 3 design, is that when that's where you support frontline providers and look for opportunities for spread. And so ways in which you can measure this include access, assess quality of care and health equity gaps. That's your measure of impact for the first phase. You test practices and studies that you do the implementation process. So that's like your hybrid type 1 phase. So you observe how the actual you're doing an effectiveness trial, but you observe how the actual treatment gets implemented. And then a hybrid type 2 or 3 is identifying and testing and scaling up implementation strategies. So that's sort of a way of thinking schematically how you get from your effective intervention to your first implementation study. So I'm doing an effectiveness trial, and how might I collect implementation data? So this is like your first phase. You're still basically trying to determine if the treatment works, but this is where you slip in some important questions around the implementation process so that you're prepared to understand what implementation strategies might work, because you've already identified some barriers in your effectiveness study that could basically be resolved through an implementation strategy. So what are some implementation process data to collect? You can think about evaluating the barriers and facilitators, one of the most common steps we start with when we go from effectiveness to your first implementation study. You asked people with different multiple perspectives, basically at multiple time points, how they feel about the treatment, what were some of the barriers in using it. These are essentially not only your study staff delivering the treatment, but the people receiving the treatment in the real world. You then also try to create a way of monitoring the implementation of the actual treatment that you don't need to rely on primary data collection for. So that's essentially looking at maybe, for example, finding ways of monitoring fidelity to the treatment or monitoring the treatment uptake using existing data. And then finally, implementation mapping is something that you'll hear more about later from JD and others, about how you actually determine a barrier and then map an implementation strategy to that to basically hypothesize how that implementation strategy reduces the barrier to provider uptake of the treatment to improve patient outcomes. So when should you plan a hybrid type 1? And I'll go over this very quickly. We covered this at the beginning, but just as a recap, basically you haven't really compared the intervention to usual care. You're not sure if the potential barriers and facilitators of the intervention uptake in usual care to inform a candidate implementation strategy or set of strategies. You still need to actually understand patient and provider acceptance of the intervention, and you need additional data at the site level, contextual factors that might influence intervention uptake beyond a single site. So essentially, you might be trying to do this in a multi-site way, and you just need more information. So here's some example-specific aims of a hybrid type 1 design we did several years ago. So it's basically determining where individual patients with mood disorders receiving collaborative care demonstrated improved health outcomes. And then we also identified as a secondary aim the organizational, provider, and patient characteristics. So this was the actual hybrid type 1 we designed that was in a health plan in Aetna, where we randomized patients to receive the collaborative care model, where they got access to a care manager and some self-management support. And then they would also either get randomized to that or get usual care, which were wellness mailings. And what we found was, essentially not surprisingly, that both ended up reducing depressive symptoms, but the collaborative care model reduced them more over time, although they kind of ended up a regression to the mean. But we also measured barriers to the provider outcome, or the barriers to actual uptake. So we found out that essentially frontline providers, the patients were liking the intervention, but the frontline providers just had too many competing demands. They weren't really they didn't have enough time to engage with the care manager in general. So we needed to basically design essentially we needed to beef up the care management part. So we learned a lot about making the intervention better, but we also learned what we need to do to design a better implementation strategy to engage more providers and using care management. So matching implementation strategies to barriers is really one of the key things here. And first you want to do is conduct a needs assessment of barriers and facilitators. The second piece is to identify adoption and implementation goals. The third piece is to basically take a framework like the consolidated framework or the implementation research logic model and map out the implementation process, identify the implementation strategies, and then finally manualize the implementation strategies in a plan with an evaluation component. This is, again, adapted from Maria Fernandez's work. So one example of how to do this is a recent publication we had in the VA. And this was actually an example of a big cultural change in the VA. And I'll tell you a little bit more about this, why this is sort of significant. This may seem kind of like second knowledge to you, but in the VA has the largest single enterprise-wide cooperative studies clinical trials program in the country. In fact, other NIH agencies like NIDA use the VA cooperative studies program to run clinical trials. So we're like the largest single entity of clinical trials, essentially. We actually had over 2,000 clinical trials currently that are going on right now. And basically, this was a program that was developed 100 years ago, and we were one of the first U.S. entities to run clinical trials for everything from like aspirin to essentially colonoscopy treatment and things like that. Well, they never actually developed an implementation plan. They never actually observed the implementation process of their clinical trials, and they were finding out that clinical trials were being published, but no one was doing the actual treatments that were proven effective. So about a year ago, we created a clinical trial implementation planning assessment tool, which had these 5 stages to basically get at information to assure that the treatment was ready to be implemented in routine practice. So that included understanding if providers and patients accepted the treatment, understanding the implementation costs of the treatment, understanding to what extent the organizational contextual factors across different VA sites were effective in implementing a treatment, the fidelity to the implementation, and then the use of the treatment in routine practice. And that's where essentially we wanted to get to. So based on the query implementation roadmap, all clinical trials in VA now are required to have an implementation plan that collects this pertinent information so that they're ready to actually get the treatment implemented in routine practice. So this was a really important pivot in the VA to be able to accept the role of implementation science in effectiveness trials. So implementation mapping is another way of thinking about, and again, I'll just review this quickly because basically these are just examples of what you can do a needs assessment. So this is like you have your hybrid type 1 and you're doing your effectiveness trial now. So these are things you can start collecting. One is basically doing organizational surveys of the barriers at the organizational level, and then interviews and focus groups of patients and providers. You're also looking at doing your implementation outcomes and determinants, basically understanding how they connect, and then selecting implementation strategies that you can use based on the ERIC framework and the Byron Powell work, and then mapping those strategies and manualizing those implementation strategies as your hypothesized reasons for how they overcome the barriers, and then doing the study and really essentially the evaluation over time, and making sure that you manualize your implementation strategies as well. So here's a quick example of how we've mapped the REP components to the evidence-based practice uptake barriers. And this was for the ADEPT trial, where we compared the effectiveness of different implementation strategies on the uptake of a collaborative care model for mood disorders in community-based and primary care settings in Michigan and Colorado. So what we found were some pre-specified barriers that included the mental health providers' lack of access to guidelines for physical health care, because a lot of the collaborative care model that we developed, which was called Life Goals, focused on physical health care management for people with serious mental illness. The primary care providers also lacked the time and bandwidth to provide patient self-management on these medical care risk factors, especially among people with serious mental illness. And then also there wasn't any reimbursement policies to provide for basically for individuals who might be presenting with depression or bipolar disorder in primary care, as well as people presenting with medical care issues in community mental health if they had a serious mental illness. So basically, the REP components were made to overcome these barriers, and you can see them listed here. We mainly used licensed clinical social workers who got additional training on the evidence-based practice, the Life Goals collaborative care model, and then we also allowed them and help to empower them to provide the self-management support to the patients and the clients in these different settings. And so basically each implementation strategy addressed a major barrier that we were trying to overcome in our hybrid type 3 implementation trial. So this is where we had an intervention that was already proven effective, which was collaborative care model, and we want to know how to implement it. So what questions do we answer in this situation? So this is a typical hybrid type 3 design. Essentially evaluating the implementation strategies, comparing implementation strategies, and then optimizing implementation strategies. So one way to think about it is again, the hybrid type 3 design. And so when do you plan a hybrid type 2 design? And I'll go first talk about hybrid type 2 design, then a hybrid type 3, because that's sort of how it's staged. But you have an intervention that has potentially strong evidence but needs to be tested in a more generalizable setting. So you have something like the collaborative care model, but you've only tested it in primary care settings. You want to test it in community mental health. You're not sure if the actual implementation strategies are ready for prime time. That essentially they need more refinement. So you use a hybrid type 2 to pilot test your implementation strategies. You then basically also need to develop that additional support and rapport with existing providers. So you want to be able to, you use a hybrid type 2 design or study typically in places that you essentially are your early adopters of your intervention, and you're willing to get some frontline providers willing to actually help you implement the treatment over time. And then you also lack sufficient numbers of sites for a fully powered hybrid type 3 design. So REAIM is a wonderful model of thinking about what implementation outcomes to measure in your hybrid type 2 design. So REACH is basically who got the intervention, who didn't. And so this is also essentially your measure of equity. You want to make sure that people get equal access to a treatment. For effectiveness, to people who got the treatment got better. The adoption is to what extent was the intervention adopted by frontline providers. Implementation is how well the intervention was delivered by the frontline providers. And then maintenance is when you go away, the researchers go away, are the places still implementing your treatment. So here are specific aims for an example hybrid type 2. And again, a hybrid type 2 study includes both a clinical effectiveness and implementation aim. And it's basically to, in this case, we had the doctor office collaborative care, which was a collaborative care model-based intervention for pediatric primary care practices to help kids manage their behavioral health symptoms. So we wanted to find out if the doctor office collaborative care model compared to usual care improved 12-month pediatric behavioral health outcomes among children with behavioral health symptoms. We also wanted to determine whether the program, the treatment, provider training and consultation was associated with improved outcomes. So our comparison group was usual care, no doctor office collaborative care, no training for providers, none of those implementation strategies. And the intervention was both the implementation strategy and the clinical intervention. So this is what it actually looked like. So I consider this almost a pilot test of the implementation strategies because, again, we only had a handful of pediatric practices at the time. But again, the sites got both the clinical intervention doc as well as the implementation strategy, the provider training and consultation. It was based on the REP model. And what they found was, not surprisingly, with a double whammy of both the implementation strategies and the intervention, the sites that got both did a lot better than usual care sites, surprise, surprise. But what we did was it successfully allowed us to pilot test the fact that we were able to successfully do provider training and the consultation. What we also learned was that essentially the providers themselves had lots of ideas for adapting the doctor office collaborative care, and it made for a better intervention to begin with. So when do you plan a hybrid type 3? So I just talked about hybrid type 2 design. We basically did a hybrid type 2 because we just didn't have enough sites. And so we wanted to do a hybrid type 3. We're itching to do a hybrid type 3 for this design because we really wanted to show if rep and facilitation could be effective. And so here's some ideas of when you want to plan a hybrid type 3. And this is really important. This is sort of really the crux of why we do implementation trials and what you need in your toolbox. First off is basically you need to have strong enough evidence of the core elements of your intervention. And so it's okay to adapt it on the edges, but you just have to make sure the core elements of your intervention have been shown to be effective in different settings. You have a way to monitor the intervention or treatment uptake at the patient level in a routine manner where you don't need to break the bank and basically hire RAs to run around and collect primary outcomes data from patients. Ideally, you need to have a robust measure of whether or not patients got better or at least got the intervention using the EHR. You have sufficient number of sites willing to implement the intervention, meaning that they're willing to volunteer their providers, or the providers are interested in basically being trained in intervention and are willing to carve out time to use it. That's the key part. Often harder to get than in reality. And we find that that's really a rate limiting step in a lot of these trials. That you have essentially, you've pilot tested your implementation strategies like in a hybrid type 2. So you have a manual of facilitation, for example, or a manual of your implementation strategies. And then also that you can monitor fidelity to both the intervention itself and ideally the implementation strategies as well. So you have to have in your toolbox a good measure of patient outcomes, a good measure of the intervention uptake, and good measures of fidelity for both the intervention and the implementation strategies. So here are some examples of our specific aims that we did. So we compared the effectiveness of enhanced versus standard version of an implementation strategy, replicating effective programs to promote the uptake of a care management program called Reengage. So in this particular example, we're back at the VA. We had to basically run a national program called Reengage, which was a brief care management program for veterans with serious mental illness who had dropped out of care and they were at risk of unforeseen mortality and premature mortality. So the VA developed a brief care management program for these veterans where essentially they provided, and they pre-identified veterans who had been essentially not been seen by the VA for at least 6 months. They also were essentially at risk, meaning that they had a serious mental illness and other chronic conditions. And they provide this list of patients to every site with a social worker who then try to contact these veterans. And so what we want to do is figure out if REP alone was sufficient to improve the uptake of the Reengaged Care Management Program, and then whether or not we needed to add facilitation. So in this design, basically we compared 2 different implementation strategies. We compared REP only, which was training and some technical assistance, and then the package, which basically showed the licensed clinical social worker how to actually find these veterans, how to use the program called Reengage. And then the enhanced REP included facilitation. And what we found in this particular example was that after about 6 months, as little as 6 months, there was actually marked improvement in the uptake of Reengage. And that was measured by the number of attempted and completed contacts the social workers made to the veterans, because the more facilitation you provided, those licensed clinical social workers were more likely to contact more veterans who were lost to care. So Jen, want to just end there and just really open it up for questions at this stage. And thank you for your time. Appreciate it. Any questions? Oh, there might be a microphone somewhere. We have a mic runner. Yay.
First, did want to say thank you for the great speech here. I have probably a naive question. I was wondering if you could give me an example of what you mean by a manualized intervention and compare it with maybe something you've seen that was not manualized. Yeah. I'm sure you have plenty.
Oh, no, not necessarily in my back pocket. You'd be surprised. But I would say the simplest example was we had a manualized version of cognitive behavioral therapy for high school kids for the adaptive school-based implementation of CBT trial, ASIC, that Danny will be talking about later. And it essentially was a couple of things. One was it had hard copies of materials that guided the school professional on what topics to cover in each cognitive behavioral therapy group session or individual session they provided the students. It basically had almost like a note card guide about what you would talk about in that first session, what you would talk about in that second session, and so forth. These were school professionals like counselors who were already trained in CBT, but they just had some notes about what to talk about next and how to sort of pace the cognitive behavioral therapy. Now the package, the manualized intervention itself was on the website. Now the program was called Trails, and Trails had on its website everything the teacher or the school professional needed to provide cognitive behavioral therapy. But the key here is that you have it written in user-friendly language, and so the implementer, or the interventionist, I should say, the person delivering the cognitive behavioral therapy to the students, knew what to basically cover in the first session if they held a group session for students, and then they knew what to cover in the second and third sessions. Or if they caught a student, if they couldn't get students together in a group, they knew what to cover in their individual sessions. And in some cases, because we used modular cognitive behavioral therapy, which allowed the school professional to maybe bring up different topics depending on the student's disposition, if they're going through a crisis, then they were able to be flexible. But it just gave them a regular guide of how to provide that therapy over time. Does that make sense?
Yeah, so I think you had summed it up earlier. Mm-hmm. It's kind of the difference between giving a easy to read, easy to use, here's your step-by-step, versus check out this research paper, give it a go. Right?
Exactly. That's
Okay.
right. Yeah. Because most research
Thank you.
papers, I mean, they have protocols that are, but they're not user friendly. They're really sciencey. Yeah.
Thank you. So my question is very similar to the first one here. So in both this presentation and Danny's, the topic of manualized came up. And in Danny's, you had talked about the crapshoot trial.
Mm-hmm.
And I would love it if maybe both of you could touch on what's going on here. Like what's behind the scenes? What's the concern with the manualized? And I did read it in the article, Amy, thank you,
Mm-hmm.
but can you clarify or say a little bit more about what's wrong with manualized approaches?
No, I think that's a really good idea. That's so many different questions in that one question. I'll try to talk about what the separate issues are. I think first off is, as researchers, we're not paid to implement. We're paid to do more research. And so when we chase after grants to get our promotions, and maybe you are, maybe it's different here, but at least when I grew up now, when I was basically publishing or perishing, I had to basically do one effectiveness trial after the other. And there were no funding opportunities for me to spend time to carefully write a manual of the interventions I did. I had to do that in our own spare time. I had to hire people who were really good at writing things better than me, and not in jargon, but in English that described what we were doing and things like that. And it's just not something up until recently that has been valued by funding agencies as an important step of the translational process. And even though we sort of like expect people to do implementation trials without spending the appropriate time to do the manualization. And the other piece too was, I guess what's the problem with it? I guess every manual is different depending on who wrote it and how many times you've been able to give it to someone if they understood it. About 25, 30 years ago when the CDC did replicate and effective programs, they actually told us on average they spent $400,000 developing each package, each behavioral intervention package. And this was like, let's say, a behavioral intervention for HIV prevention among women, among people of color, among men who had sex with men in urban areas. So they had different behavioral interventions that they packaged. And they used the term package because they realized it took time and money to carefully write out the actual intervention into lay language and to give it to people and make sure that people told them, essentially said back to them, this is what I need to do to implement the intervention. So that type of technology transfer comes from the field of anthropology. I'm not an anthropologist, so I'm kind of butchering the theory behind it, but essentially but the CDC paid for it. It was a government agency, they paid for it, but it wasn't like NIH is saying, here's a bunch of money to go and develop your interventions into packages. It just doesn't fund things that way. It funds, they want to have the new treatment that cures cancer. They want to have the new treatment that cures Alzheimer's. And so essentially there's not enough money that goes into the application. Now it's changing, but that's where we are with it.
Thank you so much. I was wondering in the hybrid type 3 trials, if you're using any of your research money towards incentives for providers, patients, organizations, and then what that is still meaning for sort of that long-term sustainability. Do you try and run trials where you don't incentivize?
Mm-hmm. No, that's a really good question. You want to answer? Yeah, you probably have some experience there too. Yeah, you should.
So we are really careful about the incentivizing in the type 3s. I would say that we do in almost every single one of them, but it's different. So like working with community health centers, we'll incentivize the health center to pay like their IT staff to be able to do some of the EHR integration, pull the data reports, some of the things that facilitate implementation, but I'm not paying the individual provider to adopt the intervention. And the reason you don't do that is you're biasing your adoption data, period. And people propose that all the time. And they're like, well, people won't do it if they don't incentivize. And part of that comes from the long-held belief of research participation should be incentivized. You could make the case that this is not research in the same sense that you're talking about in doing clinical trials where we are paying participants to do something that they would not normally do. So a lot of the type 3s that I do try to make the practice that we want to be adopted the standard of care. So it's not just saying, hey, provider, do you want to participate in a research project to implement X thing? It's like engage the clinic leadership, the higher up people and say, hey, are you willing to make this the way that you do X treatment for X kind of person? And then everyone gets trained. It's an expectation in the organization that people turn this into standard of care. And then you actually assess whether that happens. Because there still is individual provider preference choice in a lot of situations. And even if they adopt, it doesn't mean they do so fully with full fidelity. So you can still adopt pieces, but not do it as well as you're supposed to. So all those things become sources of evaluation. But yeah, this is like one of my little pet peeves right now, is that people are like paying, really high amounts for places to adopt and to deliver that is never going to actually exist in the real world. So that translational piece, like we're contributing to the translational problem by paying too much for implementation.
Exactly. That's really well put. And
Is it okay if I add to that? The only thing I'd like to add to what JD said is, so in my mind, when you're doing not an efficacy study, which implementation scientists do, and intervention scientists do. So I'm talking about an effectiveness study, a real effectiveness study. In my mind, there's a major distinction in those studies between the treatment or implementation strategy, engagement and retention protocol versus the research engagement and retention protocol. And that is at the heart of this conversation. So if you're paying someone, you just need to be clear when you're doing the real world studies, so not the efficacy studies. You need to be clear. Is this something I'm doing that is part of the implementation strategy? Which bucket does it fall into? And that's right. So in my mind, incentivize a way to get the research outcome. Bang down the door if you have to. Put all the money to that, and only put resources into the strategy or the intervention as they would live in the real world. Now, this is something efficacy researchers don't do and don't have to do. We're not holding them to that standard. They're efficacy researchers. But the folks on the effectiveness and implementation strat, the folks doing effectiveness, we do want to hold them to that.
I really appreciate the input on grant application development and the impact that requirements of like preliminary effectiveness as the focus can cause issues in research practice, as well as with study designs. On the other side of research, I'm interested in dissemination and what that should look like for like phase 1 and hybrid type 1 projects, where oftentimes the publications do focus on preliminary effectiveness. What would be a better focus for those kind of papers and publications?
in terms of getting your effectiveness trial published and everything, you said? Or just...
Well, before an effectiveness trial, so like a phase 1, like feasibility, testing, acceptability, how can those papers be better structured to contribute to the scientific literature rather than contaminating it with misguided notions of preliminary efficacy?
Sure. I'll try to give you my thoughts and love to get everyone else's thoughts as well. So I try to pack as much as I can into an efficacy study where I try to, let's say, for example, find a short, quick and dirty way of measuring an outcome that doesn't require a lot of expensive primary data collection, for example. So that's one angle, is can you pack in a paper that might maybe compare, and again, we're getting more into sort of why we're, some of the origins of implementation science come from clinical epidemiology. Can you find a good, quick measure of an outcome that doesn't require a large survey given to patients and patient burden that could be collected from the EHR, for example, or could be collected in a 4-item survey as opposed to a 40-item survey. So doing some of those validity, reliability assessments of your key outcomes would be cool. The other piece, too, is to think about ways in which you can monitor and collect information about the actual dose and duration of the treatment you're providing or intervention. So can you find a practical way of collecting that information? Because those measures, what often is really the barrier of getting from your first hybrid type 1 design to hybrid type 2 or 3 is people don't have those measures validated yet. They're just, and they go and doing a hybrid type 3 thinking the EHR as that has all this perfect data on everything, and it's very messy. And you don't have that, and then you don't have the money to pay for primary outcome data collection, so you're stuck. And so you really want to hone in on those primary, you want to be able to get those outcome metrics to a point where they can be feasibly ascertained in your multi-site trial where you're not going to be able to afford RAs at every site, if that makes sense.
Hi, my name is Jennifer Jabson-Tree. I'm at the Purdue University. We've talked a lot about, and thanks for all the enthusiasm and all of the great presentations so far. We've talked a lot about sort of the efficacy and moving of interventions and evidence-based programs and moving them forward for implementation. Can you say a little bit about how concerned we might want to be about the efficacy of implementation strategies and the packages of strategies we use to try to change systems so that the interventions can be used successfully?
Yeah. No, that's a really great question. I think the field is still very young, and people like Danny and JD especially are working on ways in which you can specify the actual implementation strategies so that they can be replicated. So what's happened, I think, up until maybe about, I would say 5-10 years ago, was that people had their bundled implementation strategy that they tested, and they may have done it inadvertently, like they were just told to implement this and they put together a strategy and they didn't quite manualize it. And then now we're at a point where we're trying to replicate these strategies and they're working with mixed effects. And I see that in my own studies, because we probably did facilitation, 4 times and we did it 5 different ways. So that's where we are with the field. So it's a very young field, but what we're also doing is we're almost like reverse engineering and figuring out why certain implementation strategies worked. So there's been a lot more literature on the mechanisms and components of facilitation, which is a whole bundle of things. Another one that's been used a lot in VA, but probably used elsewhere, has been evidence-based quality improvement, which is basically does a lot of top-down and also bottom-up PDSA cycles. Lisa Rubinstein really pioneered some of that. But, to the extent these have been manualized, it's funny. It's like, other than facilitation by Joanne Kirchner, I haven't seen a lot of manuals of these implementation strategies. Practice facilitations is a cousin of facilitation. It's the same thing. I think they have manuals there for AHRQ, but we're really at a stage where we're still trying to figure out what are some of the mechanisms of these implementation strategies and why so much more studies are being done to actually measure that. And it gets really complicated too, because you're trying to measure provider behavior change and really make that causal link between that component of the implementation strategy with the provider behavior change, and it's very messy. So, but it's why we do it. Anna, you had a question, right? Yeah.
Yes, actually, I think it follows nicely on the last one. You were talking about the push and the pull strategies, which is, I think it's a really nice way to think about these buckets. And I was curious if you think push strategies are sort of ever enough on their own, especially maybe thinking about Danny's sort of categories of intervention design, like maybe there are some where it's enough. But also, I think to your point just now about how difficult it is to measure some of these more like behavioral or maybe transformational is a good word too, strategies or changes, it strikes me that maybe it's much harder to sort of manualize or measure or study the pull strategies, and that they might actually lead to a lot more sort of micro adaptation or micro tailoring. And then it also might be harder to pitch to funders because it kind of leaves more possibility for change along the way. I'm just curious what your thoughts are, or if you were to kind of advise someone up front, like do you usually say like do a mix of these push and pull strategies, or in what cases would you suggest going more for these pull strategies?
Yeah. No, that's a great question. So when Bruce Avolio came out with his transformational transactional leadership, full range leadership development, he always said that you need a combination of both transformational and transactional leadership skills. And and I say leadership skills because essentially when you're doing a lot of implementation strategies, a lot of these strategies are really helping to empower frontline providers. You're giving frontline providers strategic thinking and leadership skills. So you do need some transactional implementation strategies to basically just be able to improve the care. And a lot of it is kind of like that benchmarking, audit, and feedback. Did people actually use the intervention, things like that? And I think the balance is really key. And so in terms of what we've seen in our studies is that you always have some sites that are early adopters, and with some training and with some monitoring, they just start doing better. They start using the actual treatment that you want them to use. It's very few sites though, but there are a few early adopters out there. Those are your enthusiastic sites and so forth. For the transformational focused strategies, that I think is where the most exciting research is happening. I think a lot of it is being able to use tools like the lists and the frame IS, which are used to capture different ways an implementation strategy gets used. And you also want to think about this. This is a whole conversation. I don't want to steal thunder from JD or Danny, but there's also I think this is where I liked hybrid type 2 designs. I used to not be a fan because I used to think, oh, you're combining the intervention with the implementation strategy. How do you tease out which is what actually impact patient outcomes? Well, what I like about the hybrid type 2s is that they allow you to at least try out an implementation strategy and kind of figure out how it worked before you go to a fully powered hybrid type 3 design. And our team has done some really good, in my opinion, really extensive fully powered hybrid type 3 designs, but we kind of didn't really know what happened in that black box in some cases. And we didn't quite know what was going on in our DEPT trial, which is the one we did before ASIC, and that was the one in Michigan and Colorado. We kind of knew facilitation worked, and we kind of knew it was because the facilitation we used conveyed a lot more strategic thinking skills to the frontline providers, and we knew that from our documents, but we couldn't quite conclude that was the case. And so the way that you track, okay, this is the other thing too, is the way that you basically are able to measure accurately what you think the implementation strategy did is that in a situation where you've hired your implementation person to be on your study team, you train them to track what kinds of skills or what did you essentially try to track what they actually provided to the frontline provider. So we have actually an intake form that Joanne Kirchner developed that tracked the different types of facilitation components that the facilitator would use on each provider that they interacted with. And that's how we found out that there were clearly more transformational skills being conveyed. A lot of it was sort of providing to that frontline provider, actually, how do you sell this to leadership? What are some of the talking points you need? How do you actually talk to your colleagues about getting help and implementing this intervention? So a lot of it was really leadership skills development for the frontline provider, and we were able to capture that. But you need to be able to really capture on a routine basis and have that facilitator do that for you, capture what kinds of information they convey to the frontline provider and do that accurately. So Joanne has a whole spreadsheet she does to capture that information.
Hi. Thank you again for some fantastic presentations. As a self-confessed efficacy researcher, doing more in the, trying to advance translation. One of the questions I have, we used to do these big kitchen sink clinical trials, like all of these things versus usual care. And then, we met Linda and we have learned a lot about how to do factorial designs to identify optimized components and combinations of intervention components. But you both have made really critical points about you take the core element or elements of your evidence-based intervention and you translate that. Which ones are those? What evidence do you need from those trials to say this is core? If it's supposed to be a 10-session intervention, but the school system says we have 4 class periods where we can cover this, do we combine things? Is it the number of sessions? Basically, I would love any thoughts about how efficacy and effectiveness researchers can think about identifying core pieces and what is core for translation. So thank you.
Great. Danny, it looks like you want to say something for this one. Okay, I'll let you talk first.
Am I saying too much?
No, you're good.
I can't wait to see how this shakes out. Okay. I think the field doesn't know how to answer your question right now. For sure. 100%. And the world I want to see is where we're doing that kind of thing, that version of what's called adaptation. I want to see that used in limited ways. Okay. But that's because I know how to design an effectiveness, not an efficacy trial, an effectiveness trial for the real world. And I don't know that, you know what I'm saying? So I think we do need to be careful, and I can't wait to see how that shakes out. It is true that you're changing the intervention. Like let's not beat around the bush about it. All right. And it's super unclear to every single person. I don't think we'll find one person, JD, that says, oh yeah, I know exactly what core means. There's no way. So in the absence of that, and because I don't know if we're ever going to get there, I want to do it in a limited way, and I want to instead have a really high quality effectiveness trial that is as real world. And that's why when I was presenting my thoughts, I want everyone to be thinking from the get-go about the actual practice setting, even the efficacy, so that the ship is going to head in that direction no matter what. And so that when we don't wait till we get to the real world and decide, oh my Lord, 12 sessions? What were we thinking?
Yeah. Mm-hmm.
You know what I mean? But that's what's happening right now.
Yeah.
We're adapting out of our ears.
And I would add just real quick too. Oh, sorry, Anna, you're going to say something? Or?
Yeah. Go ahead, Anna. Anna, go ahead.
I was just saying, could you just go a step further? We're all told scale up, go in all these different settings.
Mm-hmm.
You know, maybe the intervention that was 10 sessions was designed for the real world, but now it's being placed in a different setting. So how do you think about that challenge, I guess?
This is at the heart, of what we were saying earlier, the three of us during that first talk. When you're doing the optimization in the effectiveness realm for the intervention, you're already thinking of the scale up. You're not doing anything about it, but you're thinking of what will those constraints be. So when I go to scale up, does the intervention have to be $200 a person? Or when I go scale up, what are the constraints? Is the intervention going to have to be 2 weeks long? Is the intervention going to have to be 6 sessions? You're already thinking of that. You're not doing anything having to do with an implementation strategy yet. You're bringing those ideas to when you're constructing what I call the effectiveness intervention, which looks nothing like the CBT, the efficacy trialers did. Okay? So that's what I'm saying. We're folding that all in from the get-go. And maybe even the efficacy scientists might have thought about that. It's not in their wheelhouse. It's not their community, but they might have at least laid out some of it, right? And they're kind of thinking about it, right? When it gets to the effectiveness people, when we grab hold of it, then we really take this to the finish line. I don't know. That's sort of the only way I can think of. JD, I don't know how else we're going to.
I'll just say something really quick on a practical level. When you think about what a core element is, it's the active ingredient that makes the intervention achieve its desired effect. And the chocolate chip cookie analogy is one I use, where you make chocolate chip cookies based on the same handful of ingredients, but you might bake them at different ways, like in different types of ovens and things like that. But the best way of understanding and figuring out what your core elements are is coming up with, essentially taking your training program that you have when you train your study staff on the intervention, and how you actually measure fidelity of that intervention, how that person delivers the intervention. And that's the substrate of how you identify your core elements. So for cognitive behavioral therapy, for example, a core element is not saying I have 12 sessions. A core element would say that you manage active discussions about people's thoughts, feelings, and behaviors, about their coping strategies around their behaviors or something like that. If it's an educational program about symptom management for people with bipolar disorder, it's active discussions in a group or individual session that enables people to identify their personal symptoms they experience from bipolar disorder and be able to cope with them. So that's the core element. Like, that's what's achieved in the treatment or intervention, and that's what's supposed to happen. It's not so much saying you have 12 sessions. I don't know if that makes sense. But okay.
I'm not sure I can add more to what y'all said.
Good.
I was hoping I'd get a chance to ask some questions. So I think I have a question about effectiveness studies in general, which is, it seems like an effectiveness study is only as good as the implementation strategies. And I'm just wondering how many are there negative effectiveness studies because we haven't really done the best with implementation strategies? And as an example, I had a friend who did a study on, do bed alarms reduce falls in hospitals? Mm-hmm. And he said, well, no, but it turned out the nurses didn't want to turn on the bed alarm, didn't turn on the bed alarms.
Yeah.
So there was obviously an implementation gap. So I'm wondering about how much do we need to begin to try to optimize implementation strategies to get to type 1 effectiveness study?
No, that's a really good question. I'll try to unpack that, but I think it depends on whether or not the effectiveness study you're running is where the treatment's being delivered by people who you hire as part of your study team versus if it's being delivered by providers who are not part of your study team but are existing providers. And so if it's existing providers, there's a whole gap between whether or not they're doing the intervention with fidelity, like you said, like they just weren't doing it. So, and a lot of failed effectiveness trials can happen when there's no adequate means to ensure, again, getting back to that second slide I presented, that providers were trained appropriately to use the intervention, that they choose to use it, and they don't have competing demands that take them away from using it. So that's why most people, when you do like a trial, it's almost like an efficacy trial because they pay for the study team to deliver the intervention. You have the most control. So you train the people on your study team. You've employed them. You know that they have a certain level of education, and then you're going to get a good, tightly controlled efficacy trial going. But for effectiveness, a lot of times I've seen people say, "Well, I've hired and trained my own study team, but they're delivering the intervention in a lower resourced site." And the challenges there are less about the treatment being delivered, but more about the population. Oftentimes populations have transportation issues, or the EHR data is not as robust as your academic health system. Those are like challenges I often see more often in effectiveness trials, because the effectiveness trials per theory are the ones that you do in a lower resource set of clinics, and they often don't have the capacity to do research like the academic health systems. And so there's a whole bunch of things that you have to take care of in those types of situations in order to leap into your first implementation trial. But at the very least, you have quote unquote control over the people delivering the treatment because you've hired them. So sometimes people realistically stage that. And I don't know what your experience has been, JD or Danny, about running these trials, but do you have experience in terms of how to answer that question?
So this is maybe a provocative statement too, but I've heard Jeff Curran say it, so I'm going to attribute it to him. He basically says, his stance, and I agree with this, is that there really should not be a pure effectiveness study. That really every effectiveness study should be a type 1. And it's for exactly the reasons that you're mentioning, that if you don't know how well the implementation occurred, if you have a null finding, the tendency in the old days was to basically say, well, this intervention didn't work. There was some weird thing that happened in the efficacy trial. It doesn't actually work. And they throw it out. We're more mindful now to say, well, okay, maybe it was actually their implementation wasn't very good. But if you didn't design the study to collect the right implementation data, and I think to your point too, that you didn't use the right implementation strategies potentially too to help implement, then you wouldn't really be able to say for sure. And so you might get to the end of an R01 and be like, well, we think our implementation wasn't very good. That's why it failed. Let's try to get funding for another trial and do it right this time. Or you just do a type 1. And then you can say the failure occurred because here's the implementation problem. So we don't throw the baby out with the bathwater. We say, well, we didn't do a good job with implementation.
And I'll provide a different point of view on that, okay? Jane, your question actually, if you really think carefully about it, is where's the line drawn between the effectiveness intervention, okay, and implementation? Like, where do we draw that line? That's essentially your question, okay? Okay. And I'm different from Jeff. Like, I think there is a value to designing for what I call what he calls a pure effectiveness trial, or a type 0, if you will. You know, I think there is some value in that. I'm not saying everybody needs to do it, but I think there is some value in that. And there is at least value in knowing what that looks like. How's that? I'm going to lower the bar. Okay. We all need to know what the pure effectiveness trial looks like. And what it looks like, the way I define it, is from the perspective of the participant, in this case, the patient, because we're talking about the therapeutic intervention, from the perspective of the participant in the study, in that trial, when they show up to the treatment, Are they perceiving that a researcher or some expert is intervening on them? Or are they perceiving that this is care? That, even if we think that that's only maybe attainable within epsilon, we need to define it. And I think there's a lot of value in that, because that study, which I designed for, by the way, so I would love to have a conversation with Jeff. I designed for that when I do an effectiveness intervention trial. Like the researcher, from the point of view of the patient, is a completely different group of people than the intervention they're getting. They don't even realize that an expert is intervening on them. As far as they're concerned, they just showed up at the clinic. That is pure, and I can design for that. I do it all the time. And so then if you do a study like that tries to aim for it, even if we fall short, right, they're still signing a consent form. So we're going to fall short somewhere. But if you design a trial like that, you can feel pretty good about your effectiveness causal effect. And then you can say, okay, I'm going to seal that up. I'm going to do implementation strategies now. At least, even if we don't think it's attainable, we got to have that mile marker, JP. I think we do, man.
One more question over here, and then.
Well, thank you very much for this morning session. It reminded me of a recent example of a misunderstanding between what is an intervention and what is an outcome. And it comes from the New England Journal of Medicine, no less, and it got into CNN. And CNN had a headline, "Colonoscopy does not reduce colon cancer," a large study from Europe. But the intervention was sending a letter to potential participants to come for a colonoscopy. And over half of the people did not take up the letter, did not take up the option. And so they then reported that colonoscopy doesn't work, which was, so the fact that that should be the interpretation was extraordinary, actually. There was an editorial written by a very well-known gastroenterologist from the VA in Seattle, who made this point, but perhaps not as strongly as I would have liked. Because what they should have said is this paper shouldn't have been published in the manner in which it was written. But it gets back to your original point, that you have to know what your intervention is in order to understand what the outcome is.
You're going to believe I'm going to enlist someone like Kareem or a really top-notch behavioral scientist on how I'm going to engage someone and follow up with them after that letter. Like, that intervention is going to be real. I'm not going to just send the letter and call it the day. No, I'm going to send the letter. If I don't get a response, I'm going to do a follow-up. And that whole thing is going to be the intervention. You know what I mean? I'm totally with you.
We done? Is it time? All right. Well, thanks for your time. Yeah.